Welcome to South West London Committee for Collaborative Decision Making. It's our meeting in public. My name's David Smith, so I'm the convener for this afternoon's meeting. I'm also the lay vice chair for Merton CCG. So if we could start with introduction. So could we just do a quick whiz round the table so at least everyone knows who's here. Just to make the point that this meeting is being recorded, so and the camera is at the back. So let's do around the table, Michael.
Yeah, Mike Simmons,
GB Croydon. Roger Eastwood, lay member, Croydon.
Andrew Rose, Council Officer, Croydon.
There's Giovanni, Kingston CCG Chair.
Jim Smiley, Kingston CCG.
Sorry, can you press the microphone, otherwise we won't record your name.
That's Giovanni, Kingston CCG Chair.
Jim Smiley, lay member, Kingston CCG.
Tonya Michaelides, Managing Director, Kingston CCG and Richmond CCG.
Carol Varlam, lay member, Wandsworth CCG.
Nicola Jones, Chair of Wandsworth CCG.
James Blythe, Managing Director, Wandsworth CCG, also Merton CCG.
Jamie Gillespie, Wandsworth Health Watch.
Nicola Williams, GP in Wandsworth, but an ECI clinical lead.
I'm Jonathan Bates, I'm Director of Commissioning Operations for South West London.
Tony Pazitsky, GP and Clinical Lead for the ECI process for South West London.
Michelle Rahman, Acting Managing Director, Sutton CCG.
Pippa Barber, Independent Nurse, Sutton CCG.
James Murray, CFO for South West London Alliance.
Bob Armitage, lay member, Richmond CCG.
Graham Lewis, GP Chair, Richmond.
Claire Gummett, lay member, Merton CCG.
Sarah Blow, Accountable Officer, South West London Alliance.
Andrew Murray, GP Chair, Merton CCG.
And colleagues at the back, can you just record your names, please, so it's on the record?
I'm Lizzie Wetnall, Head of Communications for Wandsworth CCG.
Zolly Zambo, ECI Programme Lead for South West London.
Emma Whitaker, Administrator for this meeting.
And Jeff?
And Jeff Cratchit, Sutton CCG, Governing Body Chair. Good.
Thank you, and I think we've got a full house from each CCG. So, so let's, if we go on to item 2, declarations of interest. These have been tabled. Has anyone got any other declarations they need to declare for the purposes of this meeting that aren't recorded on the register? I'm just looking around the table. No? Okay, we'll take those as a correct record. So moving then on to item 3, it's the South West London Effective Commissioning Initiative Policy. The paper is in the pack. So with that, Jonathan, shall I hand over to you to give us an introduction to the pack, and then it will be open to questions. Thank you.
Sure. Thank you very much, David. Time flies, doesn't it? It was some 15 months ago, I think, we were here as a committee in common agreeing version 2 of the effective commissioning initiative work that we've been taking place over South West London. Here today to talk about version 3 of this policy, which takes account of a number of changes and updates since the previous version. And the pack, the slides also give you a bit of an update on what has happened through the implementation of version 2 of that policy. I think it's worth acknowledging at the outset that South West London really is in the lead around this area of work, both regionally and nationally. A lot of the work, as Tony will come on to say, that's taking place across London through the Choosing Wisely programme builds on the work that's taken place in South West London, and indeed we're one of the national exemplar sites for our work in this area, and the national team often come down and talk with us about where we're at and how they may evolve national policy to help support it. So it's in a good place, I think, would be my starting point. I think I will walk through the slides together with Tony and Nicola. So if you've got the slide deck to hand, the first few pages just reiterate really what an effective commissioning. I'm trying to get the slides to start.
Sorry, Jonathan.
So I imagine most people have got paper copies in front of them, but if anyone wants to see them on the screen, they're here. And one's gone to the clock on the other side. So, but if you're in the public gallery, at least you can see the slides that we're presenting. So the first slide just describes what an effective commissioning initiative policy is. So it's primarily around planned care procedures, and it doesn't encompass emergency cancer or maternity care services. And this is an evolution of work that's been taking place, perhaps not with this intensity, but really an area of work that's been in place ever since really primary care trusts, the predecessors to CCGs, were in place. Tony, Nicola, would you like to talk through the where we are in terms of why we need an effective ECI policy?
So just to remind everyone, the effective commissioning policy is about clinical effectiveness. So at one end, it's about protecting patients from procedures that are ineffective or have no value or extremely limited value, through to, at the other end, identifying patients who would most benefit from treatment so that they have priority and are able to have their treatment done. There's a wide range through that. So, for example, some types of procedure arguably would benefit everybody, such as if you have a cataract, having a cataract procedure may benefit you. But if you operate on everybody, 25% of people will be disappointed with the outcome. So it's a question of identifying those people who would most benefit, who will get the most, would be able to get the best quality of life following a procedure, rather than offering a procedure to everybody with every condition in the NHS. I think that sums it up, Jonathan. Thank you.
Great. Thank you. So in terms of the version 3 scope, just to clarify what the changes and amendments have been from the previous version of the policy, and they really fall into the 4 areas set out on the slide presented now. So some are about updating the existing work that we've done. So, for example, in tonsillectomy, there's some work that we've done to clarify the number of episodes that you need, or in the case of hernia repair, clarification about what does and doesn't apply for children. The second is to take account of the national programme. So there was a national consultation and the statutory document released last year, which set out a number of areas. There were 2 areas that were in addition for South West London that weren't in the existing policy. One around shoulder decompression, the other one chalasia of the eye. And then about adopting clinical thresholds that other London CCGs have adopted over the last year through the Choosing Wisely programme that I referenced earlier, and those are set out in the slides as well. And then where there was new clinical guidance or thresholds have been developed, and local clinicians felt it was a priority to reconsider or consider for the first time our approach. The implication is that the number of procedures in the document goes up from about 55 to around 60. That's the practical implication of where we are. So side 3A just says a little bit more about those areas of work. So there's been the horizon scanning work involving public health colleagues and national work. There's the work with the Choosing Wisely London programme, which Tony's going to talk about a bit more. There's the work I've already referenced from the evidence-based intervention programme that's taken place nationally. And of course, we've spent a good deal of time talking to local clinicians across a range of organisations to ensure that the policy is as comprehensive and accurate as it could be. And the next slide just details all those people who have been involved, while the subsequent slide to that lists all the procedures, with those highlighted in red being new or having had significant amendment from the previous version of the policy. So that's sort of covers the key areas that are set out. There is a slide that sets out the national work on evidence-based interventions. And Nikki, do you want to say a little bit about
I think
that?
yes, so Jonathan's talked a lot about it, and this work came along whilst we were doing this review, and I suppose the important thing to note is that South West London has fed into the national team on the work that we've already done, as we're ahead of the curve, and they've taken on board a lot of our recommendations, and they've also come down to talk to us and visit us to discuss what we're doing. And what we have done is made sure that our current version of the policy takes into account the work that's been done nationally, so that people don't have to look at several different versions. So we have ensured that our policy meets these requirements. And the next slide lists the different categories. So category 1 of the national policy is that these will be zero tariff procedures, and the 4 are listed, and category 2 are the ones that are subject to clinical thresholds. So as Jonathan already stated, we already have clinical thresholds for all of those apart from 2. So the new policy will now have new clinical thresholds for those 2. And I don't know, this just shows where we are on these procedures compared with the other CCGs.
Yeah.
And as you can see, we're right down at the bottom.
I mean, I think what I was trying to demonstrate there was the work we'd already done was having impact to be the second best performing STP in the country. Doesn't mean there isn't further work we can do, and some of the work, for example, around back pain, for example, where we are at a much higher level than some other parts of the country, but it does demonstrate that we've already made significant progress.
And then the next slides, so 5A, tell you something. So there's another piece of work that actually started before the national work, which is where we're looking across some of the procedures to develop a London policy so that all of the STPs had the same policies across London. So that was London choosing wisely. And South West London had a large amount of representation on those groups, chairing some of the groups and sitting on the steering group. And what we have also done is incorporated the policies that came out of that piece of work into our policy as well. The aim being that actually as a provider, so GPs and hospitals, people don't have to think about 3 different policies, it's all in one. And it gives you some idea of the timelines of that work. And the following slide is the procedures that were covered in the London Choosing Wisely work. And again, we had policies for all of them apart from the shoulder decompression, which is now included in the new policy.
So I'll go through some of that. So there are some new clinical thresholds. I think it's easiest just to explain why. So the first one, Botox for axillary hyperhidrosis, we got asked to make some recommendations by the IFR service following variability around South West London, which we hadn't picked up in our first piece of work. The chalasia removals in NHS England one, which we've included. Complementary therapy, we already had a policy, but it's now a standalone policy rather than part of other policies, which makes it much clearer, much more user-friendly. The intervention for snoring, but not for obstructive sleep apnea, was already covered, but is now also part of the national piece and is being separated for clarity and ease of use. Photodynamic therapy, which is a treatment for skin lesions, benign skin lesions, has been included. There's huge variability across South West London, and it's a case of ensuring equity and making sure that those people who will benefit from photodynamic therapy have it, as opposed to everybody having photodynamic therapy when there are other much simpler treatment options available, including much of that in primary care. Scrotal surgery was included in that a lot of the procedures done were for benign embryological remnants, such as epididymal cysts, and patients undergoing these procedures, usually for cause of anxiety, were unaware that they have a 10% chance of lifelong untreatable scrotal pain post-surgery, and we felt it was important that patients didn't have procedures for things that didn't affect them that could have a long-lasting effect on life. And shoulder decompression surgery we didn't include in our first round of screening because for South West London the volumes are relatively low and it wasn't seen as a priority, but it's seen as an ineffective procedure largely by the national team, so we've included that to be in line with the national guidelines and the London Choosing Wisely Standards for London piece of work. Thank you.
Thank you very much, Tony and Nicola, for describing that. So the next slide just summarises the secretary duties around quality and the quality impact assessment. So colleagues from the CSU together with the directors of quality have reviewed those that they feel are appropriate and need review for from an equality impact point of view. So we have undertaken that duty. And then the final slide before we move to questions is just to remind people of the process. So after all the work that we've just been talking through, the hope is that we're able to reach consensus and sign off version 3 of the policy today. The reason for scheduling that for today is we need to give providers a month's notice if it is to have contractual impact for the 1920 year. So we need to signal by Friday that we plan to put these new arrangements in place. And of course then through March that will give us an opportunity to liaise with primary care colleagues, acute community, independent sector providers where this will impact, so that people are as au fait as they possibly can be with the policy before it launches on the 1st of April, subject to agreement of this committee. So at that point I'll pause.
Thank you, Jonathan and colleagues. So this is for approval by this committee, by each CCG as a member of this committee. So before we do put that to the vote, as it were, so questions from members, and perhaps if I just go around this way, and let's start here and then we'll work around.
I've just got a query, not necessarily about the detail, about probably the implementation of the ECI policy. So I do know that in some areas, different clinicians have vastly different procedures against their name compared to other clinicians or other surgeons. So how are we as South West London going to be looking at those individual clinicians rather than it as a trust-wide or a South West London-wide?
So this is a question we have discussed. There may well be, if someone has a particular speciality and it's a high tertiary type procedure, that they would quite rightly have those procedures listed against them, and others probably shouldn't have any. Others it may be variation in practice. So I think the only way to look at that is to do some focused pieces of work, perhaps including clinical audit of what's going on, to ensure that the policy is being complied with and that equity is being served across the patch, and as well as that to ensure that our regulations or guidance is fit for purpose in case someone is feeling so strongly that they should continue contrary to that guidance. I would have to say that we have sought input from absolutely everyone within the sector. We have had some questions coming in, and any ones that we haven't yet resolved at this moment will be picked up with the next iteration, and that's being planned, and we have those under review, and they're being researched by Public Health as we speak.
Can I just, and just one statement, I just want to congratulate the team on the amount of work that's gone into providing even version 3, because I know how much work was in it in version 2, and all the constant to and fro between clinicians. So I do congratulate the team on getting here.
I'm interested in the interrelationship between the ECI policy and IFRs. Has there been an increase in IFRs since this has been in play?
So other people will probably want to comment in more detail, but in fact the opposite has happened, because there's much greater clarity across South West London about what will and won't get funded, and if you're able to convey that to clinicians, be they in primary or in secondary care, I think it's much more likely patients will end up travelling down the right path for them in the most timely way. So other people might have a bit more detail about the numbers, but I know there's been a reduction as we brought it together under, as you know, through a separate decision this committee made into one IFR panel across South West London.
Just thinking about this programme from the public point of view, these programmes can be really worrying for the public, and I think they need, above all, reassurance that there has been consultation. Now, I know there's been consultation, but it doesn't really come over in the documents. I'm reading about PPI engagement and communication, and it just says draft versions of the policy were shared with patients, and patients were involved in the task. It would be really reassuring for the public if we could have just a bit more detail. You know, for example, PPI trails through the boroughs would be enormously reassuring.
Okay,
Jonathan, can you
well, I think Tony's
just
going to
say a
have to
little,
start.
Tony, just say a little about what we've been.
So I think that's a very valid question. The significant part of the updating for version 3 is bringing our programme in line with these pan-London piece of work initiated by the Medical Director for NHSE London. There has been a huge amount of public engagement as part of that process, and replicating it all again I'm not sure would add significant value. I was on the steering group, and there were at least 3 patient representatives representing a wide range of organisations and linking back to those organisations, as well as a widespread campaign of getting in touch with all interested medical and non-medical organisations, including all of the health watches in London. So it has really been at a level that would be almost impossible to achieve at a local level. And each of the individual groups, and Nikki sat on the musculoskeletal group and I sat on the cataract group, replicated the same process with interested patients on each of the groups, and again calls going out for advice, comments, feedback from patient groups as well as specialist interest groups. So of the remaining ones that have been changed, we have had a discussion, and Carol has attended those, but those were highly technical discussions about 1 or 2 small groups of patients that specialists felt that they had been disadvantaged and unable to treat, particularly around back pain. That was led by patients saying that I'm no longer able to have treatment, and I think we've responded to that as best as we can. So I hope that we've done a good job. Maybe we should put a little bit more in the pack for the public around the engagement that has taken place, because I agree that it doesn't look as if we've made that effort that we should have done and that we haven't listened, but I can assure you nothing's further from the truth.
I know you've done a great job, but you just need to say that.
Point taken.
Carol, is this on the same point?
Just on this point, I think some sort of public information leaflet would be really helpful that could be shared with patient and public groups in local CCGs, Health Watch, all over the place, just what the policy's about and so on. I agree with Jamie.
So that was exactly the sort of thing that we had to do when we implemented version 2, which obviously was a much more significant change than the relatively modest set of changes we're making now. But the intention exactly is to do that, Carol, is to reinforce and repeat the communication routes that we put in effect 15 months or so ago.
And you will remember, Carol, from version 1 that we were absolutely clear that patients should have informed decision making, and we've enshrined that, and that's become pan-London and now national policy. So I think there's a piece of work for us to work on that guidance so that it's uniform now across the patch and freely available to patients. And as soon as we do that, anyone who has a procedure will realise the amount of effort that's gone to help them make a decision. So I think that's coming and will be part of the ongoing work.
One more It's not just the patients, it's the public. It's the public around it. If you're a patient, you do get the information, it's very well done. It's understanding around where there might be suspicion.
Thank you, Jonathan. Just a point of clarity. I think I heard you say, so when you were going through your slide, you talked about the equality impact assessment. Has a QIA now been completed for this quality impact assessment?
So my understanding, I asked that very question this morning, Pippa.
Great.
So there was a conversation that I know Zolly's had with the directors of quality, particularly Julie Hesketh this morning, to confirm that has happened. So that's what I sought some assurance of this morning.
So you had assurance that it had happened?
Yes.
Okay, and that's available to all the CCGs?
So that is I think that's a very reasonable request, and we're absolutely happy to make it available. It should be made available. Being totally frank with you, I haven't seen it. I've asked for it, and I've been given the reassurance it is available through the Directors of Quality. So there's no reason why we couldn't share that, Pip. I'm very happy to do so.
Thank you.
Just to say, we discussed this at Richmond, and we've acknowledged all the work that's been done and the fact that this builds on work that's already been going on. So it's not new in that sense. A few comments. So it has been discussed in Richmond. I was delighted to see in 3B that Phil Moore has been appointed as an honorary member of our CCG, which is probably a slight surprise to him, but we have had several of my colleagues who have been actively involved, which were not on that. The point was made to get this down. How do we get this out to the public and the patients, and to replace the documents that my colleagues already have, and make sure it's indexed and easy read for a GP on the ground, accepting that most GPs refer for problems rather than procedures, but often patients come back for explanations, so we need to get this out into the wider fora. And I suppose the last comment was on 4B, was it? What are Gloucester doing that we're not? As we should be number one, probably.
We can always aim higher, can't we, Graham? I think it's the message.
Just a touch.
Okay. Are there any other questions or comments on the policy? So we need to then, let's just put that, I just want to go around the table to each CCG so we record the position of each CCG on this. So, Croydon?
Croydon approve, yeah.
Yeah. Kingston?
Kingston approve.
Wandsworth?
Sutton approve.
Richmond?
Richmond approve.
Merton approve.
Okay, with that.
So the policy has been approved.
So the policy has been approved, and thank you again to everyone for the work that's been done on that. Okay, thank you very much. Okay, so let's move on to item 4, which is an update on the planning round. Because this is work that is ongoing at the moment, there's a paper that is being tabled. A number of people here were at the Finance Committee in Common that we held last week, so there was an update for the members of that committee. But again, we've got something for the whole committee here, and this is for information, it's not for a decision. So who's dealing with this? James, is this you, or is it Jonathan?
I am.
So there is, everyone should have a table copy of the slides. So Jonathan, perhaps you can.
Yes, I'm just going to let Emma get the slide.
We've got a paper copy, but just crack on, isn't it?
Okay. Give them that, Emma. It's okay. We'll just use the paper copy. So it's a very different item from the previous item. This is really just to bring people up to speed with where we are in the planning round. Of course, a great deal of that takes place at a local level, and many people in this room will be much more cited than I am on the local arrangements that have been put in place and proceeding at pace at this time. So I think James and I are doing a bit of a double act on this. So really, I'm just going to talk you through a few high-level slides that tell you where we are at this point in time. Had we had a larger public audience, I might have spent a bit more time on some of the earlier slides, but won't in the circumstances. But the first of the slides, so the slide entitled Operating Plan Requirements, Key Deliverables, really sets out from the planning guidance published just before Christmas what the key expectations are of the system. I'm sure people will be familiar with this. You can see the significant number in mental health, particularly covering all aspects really of mental health, a real step up in terms of the expectations expected of systems. You can see the further transformation work expected in urgent care redesign, particularly the commitments around ambulatory care that stand out for me. Some of the challenges we face as systems to continue to maintain elective waiting time standards and access for patients, and as colleagues will probably be aware, some of the penalties associated with the non-delivery of that for patients who wait an excessive period of time. And I suppose the other one I would flag is the step up in expectations around cancer performance and the move to the 28-day standard. Of course, there are more than what I've described listed, but I'm sure they're familiar to most people. The next slide is, as colleagues will know, we issued our commissioning intentions back at the end of September, and this was really just trying to aggregate from the key local messages to some sort of South West London wide messages around what we plan to do differently in 1920. So again, I'm not given people will be familiar with this and will hopefully have an opportunity to read this at the leisure. I wasn't going to spend a great deal of time talking about that, but just to flag that's what we said we were going to do in our annual commissioning intention cycle. So that's what we should be trying to get contractualised through this current planning round. And the next couple of slides are really about the approach to planning and where we are in that cycle at this point in time. So we spent, as you would expect, the summer months working out what we wanted to do through this planning process. The autumn planning, how we were going to do that, including some detailed things on activity and financial modelling. And then we're now in the phase of negotiating contracts and finalising them, and in extensive submissions to the regulators around delivery. To support that, in the diagram that's a little difficult to see, but the table is difficult to see, you can see the structures we put in place. There is a joint planning forum that we've established for the first time between providers and commissioners, sort of assistant deputy director level. There's a finance and activity committee that James chairs that brings together the finance directors across South West London to address collective issues, and then there is a chief executives group which Sarah leads to seek to resolve issues that cannot be resolved through other fora. And the diagram on the left-hand side also shows that internally we have 6 work streams focused around activity, finance, QIP, performance, quality and contracting that meet very frequently. Some of them meet weekly since the summer to get us in the best place as a system to respond collectively across South West London. And then the final slide, the spot diagram, as we often call it, really talks us through where we are in the process at this point in time. And you can see for our main acute and mental health providers where we are in terms of negotiating an agreed contract position. I'm not proposing to go through that in any detail, but this is one of the things that we use to monitor through the contract delivery group, where we are at getting the right things into contract in a timely way. And you can see we're about halfway through that process with still a significant number of steps. I'm very happy if people want me to talk through the headings on the top and what they represent. They will be very familiar to some people and perhaps less familiar to others. So, but for the sake of time and expediency, I wasn't proposing to talk about them in any great detail here. So that would be my sort of brief synopsis of where we are on the contracting round as a sort of high-level proposal for this forum. And I was going to hand over to James for the couple of slides on finance.
So we've just pulled out when we had the Finance Committee in common. We talked about having a single message going into governing bodies around the allocations. So this is what we've got here, and it will come to each of the governing bodies next week when they meet separately. But just to give you some high-level points, really, from here, as David said, I laboriously, I think, took my Finance Committee chairs in through where we're up to on the allocations, and I'll do a much simpler version for here. But suffice to say, although they said next year would be a year of stability, they've made a number of changes to the regime, which we're even now currently working through with provider colleagues to understand what the local implication of some of those are. But we're well on the track to doing that now. But it has introduced some instability and some change into the system, despite it being a year of stability. We know that they're reviewing it in full over the next 12 months, and therefore it's likely going into the following year there'll be some further changes to that. But if I just briefly, because this has been presented, just run through the sort of high-level messages coming behind this. The top one, which I think is critical for all organisations, is the clear steer to get the NHS back into a financially sustainable position, and all the organisations within that as well. So as we've got a much more confused sort of NHS finance system with control totals and with various sustainability funds and all these sorts of things, there's a kind of trajectory to steer us out of that and get everybody working to what I would call more principled sort of financial sustainability rules. And therefore they're looking over a period of time to reduce some of the sustainability funds that we've got in place, and that process has started. And also introduce, just for another acronym for your arsenal, the Financial Recovery Fund, but that's much more targeted at helping organisations towards that financial balance. So there's £1 billion gone into that this year, but it's only targeted at certain trusts, and there are certain commitments that they have to follow to access into that. 3 trusts within South West London have been offered some of that at the moment, and discussions around that are ongoing around what that means. The other thing to say at the moment is we've been set our 5-year allocations. They're 2 years are fairly certain, 3 years are indicative. We do know, and I've had conversations with people at NHSE, that there are still some monies, certainly more in the later years than next year, that are currently held back and will be used to support the transformation delivery of the 10-year plan. We don't exactly know what those are going to be. Even when asked the question, I'm not sure they know exactly what they're going to be used for, but there is some money there. As part of the planning guidance, we're going to have to do a 5-year plan over the summer into the autumn, and I'm sure further guidance will come out over that period in the subsequent years, so we can actually place some of those resources into the system. So we'll let you know as we get further clarity on those how that's working through. The mental health investment standard is still there, so we're expected to fund growth plus 0.7% on that, so that's a commitment we have to make. One of the significant changes we've flagged before is, for people who aren't aware, we have what they call the market forces factor within the NHS. So parts of the country which are more expensive than other parts to employ people, to run buildings and all these sorts of things, get a supplement to their normal level of funding. Truro is the cheapest place in the country to run a hospital, and understandably Central London is the most expensive place. They haven't reviewed this formula for a number of years. They have now. London hasn't done very well out of that, so it's basically said, the analysis, to cut it down to its crudest sense, is that there's a number of changes to the labour market that mean that outside of London has caught up a little bit in terms of costs to London. So those have been tapered in over a 5-year period. It means trusts get a little bit less extra income. we're not losing any income or allocation, but it does affect our capitation target. So our capitation position, we get further away from that, and that does affect growth going forward. So as a system, one of the things we'll have to work through with our provider colleagues is how we manage that transition in a sensible way that doesn't destabilise any services. The first year impact is relatively small, but it does get bigger as we go further into the process. But as you can imagine, there were a lot of discussions around the implications of that. Our headline cash growth for South West London is about 5.68% across the 6 CCGs. It does go up and down a bit, so Croydon are below their target, so they get a bit more. Kingston are above theirs, so they get a bit less, but broadly it's that. And we're more or less at the national average of 5.65 and slightly below the London average of 5.78. For next year. They have made some other funding formula changes apart from MFF, so they've changed the way they do mental health. They've changed some community services. South West London in particular, Kingston and Richmond haven't done so well on their capitation position against the mental health. But again, it doesn't lose them money directly, but it does affect their capitation position. And excuse me. So those changes are embedded into the 5-year allocations as well. For next year and the next couple of years, the key messages are, I think, so we've got 5.7%. Sounds a lot, but there are some caveats to that. So one of the things that they've done, if you remember earlier, I said about changing the sustainability funds. They've reduced what they called the Provider Sustainability Fund, which went directly to providers through discussions with NHSI, and they've now included that into the non-elective tariff. That's about 1.3% of our allocation. So of our 5.7, 1.3% we just pass straight through to providers. It's part of their funding. And the whole ethos behind that, again, is trying to get providers into a more financially sustainable position, because every provider would argue, and probably very rightly, that they lose money on non-elective work at the moment. The other thing that we have to do is obviously fund inflation. That's been calculated at 3.7% there, and that also includes last year's pay inflation as well. So effectively, it's got 2 years' worth of pay inflation, and obviously that's coming out of our 5.7%. The other thing they've also done is reduce the trust efficiency requirements down to 1.1%. So again, that's money we can get back into the system. But it is lower than it has been at previous years, and it is part of the reason that's been driving trusts into deficit when they've had sort of 4, 5, 6% CIPs year on year. So again, back to my start point, all about the philosophy of trying to get organisations back into balance. That's what they're trying to do. Trusts who are in deficit actually have to produce another 0.5%. So back to that financial sustainability. If you're in deficit, you have to do a higher savings target, but it's not in the sort of an extra 3, 4, 5, 6% sort of margin that we've got at the moment. CCG running costs, we had the letter. That's been reduced by 20% from 2021. And we're working through the implications of how we manage that. There's no reduction next year for that, so it all kicks in from 2021, but we are working to make sure that we can deliver that from April the 1st of that year. So there's processes going on to feed that through. So what that means is that of our 5.7%, we've got 3.9%, which is sort of pass-through costs, if you like, which leaves us with about 1.8% left to sort of balance our growth and other pressures, mental health standards and all those sorts of things. It does vary slightly, and we've got all this by CCG. We shared it with by CCG with the committee in common last week, and that will be coming to governing bodies where we're up to next week on that, so they can look at their position individually. The other thing just to say at the bottom there, which is quite critical, all organisations have been set their own control total. They've been set, I think it's by NHSE for CCGs and by NHSI for trusts. I think it's fair to say they haven't necessarily looked at local systems and said, do those two things make sense? So that's one of the things we're having to work through as we go through that, but that's something we'll explore. What the guidance says, generously, is there are a facility to move your control total between organisations, but you can't change it overall. So the money is the money. But if you can find somebody who's generous enough to underspend, then we can manage some of the pressures elsewhere. That's a major culture change. So we know with the CCGs recently, in the last year or two, we have been looking at that and doing that at the edges, perhaps, with the CCGs, of how we balance the CCG Commissioner control total. We're actually looking to do it across the whole system now, and that throws in a whole further set of implications, which we'll work through as we go through this planning round. But we have started those discussions in the committee in common, and we'll obviously feed those through, but they will always come back to the local governing bodies for deliberation as well. But that does give us that facility to pull those together. The final slide you've got there, if I just flick over to the pretty picture, is the bridge analysis. I won't go through it in a huge amount of detail, but the red ones show effectively where we've got commitments. The green ones are showing where things are to our benefit. There's a lot more red and green, as there always is, and the blue ones just effectively set where we are as a position. So our forecast outturn as a set of CCGs, and this isn't our control total, this is our outturn, is a £700,000 deficit. There's an underlying movement on that because we know that people have managed things on a non-recurrent basis, and that affects particularly Richmond, Sutton and Merton. So we've got an underlying adjustments there to give us an opening underlying deficit of 15 million. We get the extra income in the green, the big number of 123, but then what we've got is a series of pressures exactly around the things that I've talked around in terms of inflation, growth, the pass-through costs on PSF, mental health investment standards, some local investments. We've set up an acute reserve and some contingencies, and then there's a few technical adjustments which at the moment we're just working through with the trusts exactly how those fall through. What that as ever does is gives us a big quick target for a bunch of CCGs to deliver. It's about 87 million this year. We're still about 20 million short of that at the moment. We're working through that, but clearly the difference for this year is that we're having to work that in conjunction with the trusts. So because of the system control total and the fact that they don't go to NHSI and we don't go to NHSE, we go together, we have to take a much more holistic system view of that. Makes it a whole lot more challenging in a number of ways, but a more sensible approach, I think, as we go forward. What that means at the end, if we do deliver that, is that we'll have delivered a £4.3 million surplus, which is our control total. The bulk of that is for Croydon to get back to their 1% surplus next year. So there's a couple of smaller surpluses for Sutton and Richmond. Suffice to say, as we go through in this, the biggest risks that we've got in the QUIP programme sit with Richmond and Sutton, where when we look at it at CCG level, they've got a very high proportion of QUIP compared to the others based on their start point. And as I say, we'll work all that through. I'll just take stock there if anybody's got any questions or queries.
So before I throw it open, Bob, is there anything you wanted to say just as the chair of the Finance Committee?
Only to say that we had a very thorough and rigorous discussion about this and we're supportive of James's approach.
So I mean, this is still work in progress. So, but I'm happy just to take a couple of questions. So, Naz?
Just a small point of clarification. Do we know how much is being held back on the allocations in the later years? And I'm presuming that's going to be completely separate to the FRF, which is being held for the provider costs.
So. I don't know.
Okay.
They wouldn't tell me when I asked them.
Okay, fine. Right.
So someone there will be sitting with a big unallocated number, but I don't know what it is. But I think what it will come out with is support of what they think are the main strands of the 10-year plan. So I haven't heard any more about it.
I don't think they know yet. I would assume that if the systems aren't moving into balance, they will put more into FRF in order to push the systems into balance. But who knows? And you know what they will direct that towards. I'm sure it will be around the long-term plan, but we don't know which areas and how much.
Yeah. Certainly for next year, the message we're getting is the money, and you've got it. So.
I just wanted to make some comments as mental health lead for South West London. So very, very pleased to see the increased number of targets and commitments for mental health in the operating plan and that follows through the long-term plan. But of course that comes with extra scrutiny and assurance. And as James said, very pleased to say that in South West London we are making the mental health investment standard. CCGs will be audited on that, and we will have to make a public statement that we've achieved it. However, I don't think that's the only area or question that will be asked of CCG. So one of the questions that has emerged recently is, are you making the mental health investment standard, and are you investing enough to make the priorities? I think that's a really difficult one, because it's almost like, where do you stop? Because, you know, the investment in mental health just nationally has been low over the last decade or so. So actually, how do we make good? And actually, how do we then invest into services going forward? We are trying to have a very different, we are having a very different conversation with South West London St George's, both as a standalone provider, but as part of a South London partnership. And we're talking with our South East London colleagues about how do we have a different kind of, rather than having the traditional, here's a load of business cases, please invest, or actually what can we do together collectively to meet the priorities and the challenge we have in mental health. So it's an emerging piece, but I would be expecting more scrutiny through the next financial year around mental health, and particularly mental health investment for the priorities.
Thank you, Tonya. Any other questions from anyone? Okay, let's note that it is work in progress, as James was saying. An update will be coming through to each board anyway. So thank you for that. Item 5 was public questions. We haven't been notified of any questions in writing, and there aren't any members of the public here, so I suggest we pass over that one. I haven't been notified of any other business. I assume no one's got any other business? No. So with that then, we'll close the public meeting, and then we'll go into our part 2 meeting, where we've got a couple of items. So thank you.